Hello, everyone. Hello, everyone. Welcome to our Zoom meeting. Today, the team will present different topics. So I'll hand it over to Dr. Mohammed and his team. When you are ready, please go ahead. Thank you so much. Hello, Dr. Omar.
Thank you, Dr. Nader, for the opportunity to share this floor with you today. Hello, everyone. My name is Mohammed Al-Abbadi. I will be moderating the meeting for today. So without further ado, I think we can start if our first presenters are ready for the first topic, cardiovascular and older adults. Dr. Abeer and Dr. Hibatallah, if they're present.
Hibatallah is there, but I don't see Abeer.
Yes, I think maybe they're running behind. Okay, we can move toward our second topic if the presenter is ready. We see Dr. Thilini also on the call.
Why don't we start with Dr. Mafaz? If you are ready, Dr. Mafaz, can you give us some tips and maybe you can share your experience if you are here, Dr. Mafaz?
Yes, hello, good evening, everyone. I hope everyone is doing well. Mafaz Ombada. I was previously in the program at the TGRF Research Fellowship. It's nice to see you again, Dr. Nader.
My pleasure.
Yes, so I'll speak briefly about my experience in the program itself and how it helped me overall, and still it helps me a lot today. So I joined around February of 2022 or 2021, and then I initially also had the same issue where I didn't know where to start, how to initiate the research process, and all the technicalities that goes into it. However, with all the things that Dr. Nader did and how we were able to form groups of interest, so I was able to publish around 4 or maybe 5 abstracts currently, and soon I'll be able to present an abstract with Dr. Haifaa at the American Asthma and Allergy and Immunology Conference in San Diego. And part of the program itself is how we present different topics each week. And that's a very excellent way for us to practice, because even when you hopefully match into your residency, you will be asked to present some different topics. So it will help you arrange your thought process, your presentations, your PowerPoints. So it's a very excellent way to do it, and don't be shy or scared. You might not be the best in your first presentation, but it will keep on improving. And I encourage you to always find a project, even if it's not one of your interests in the future and you're aware, for example, you're interested in geriatric, or maybe you're not interested in, let's say, internal medicine, so not geriatric population. Just ensure that you join a project, and just for you to learn about the process, because it's very important for you to benefit and learn how to start the research process, how to gather the information, how to research the process of how to research the information itself, and how to find your results is very important. And then during the whole program, there were some friendships and camaraderies that formed, and I'm glad that I'm still able to keep them. So yeah, it will be overall like very helpful. And does anyone have any questions?
I'm very glad that you shared your experience, and I'm very glad that you had a good experience, Dr. Mafaz.
Thank you, Dr. Nader.
Congratulations for the abstracts and the last one. So good luck with the presentation.
Thank you.
So how is the residency and how is the fellowship, if it helped you with any ideas research-wise during your first year and so far?
Yes, so I would say the residency, of course, as you said, the first year is always the hardest. So it's very important to take care of yourself and have your friends and family close. So part of my support system was also my family, as well as friendship that I had from telegeriatrics. I remember calling Dr. Nawood, on my first few weeks, and I was like sharing my experiences with him, and he just told me to keep my head up and just continue going forward. And then in terms of the research process, I have started a couple of research with my colleagues at work. So I can say that it helped me a lot because I'm able to currently start the process easily, or I have a better idea or view of how the process that I want to go into with terms of research. As well as presentations, it's easier, I would say, with all the practice that we had during the telegeriatric program.
Excellent. Thanks so much. By any chance, at this time, do you have an idea of what your plans for the next couple of years, if you want to go in a specific direction or not yet?
Yes, I am interested in going for a fellowship in gastroenterology.
Good.
Yes.
Excellent.
Thank you. And one of the topics that I going to be presenting is about the eosinophilic esophagitis and how food elimination diet can be used as the preferred method in management other than the steroids or swallowed steroids.
Excellent. So hopefully when you go to the conference, you can make connections. But I would like to also encourage you to get some ideas, and if you can involve some of the fellows here in your research ideas and projects, so you don't have to do the whole 9 yards, all the task of doing a project. So your residents, co-residents, and you can start some, but if you want to encourage some of the fellows in this program to join you, that will help you and will help them as well in the future.
Yes, I have actually spoken with some of the current telegeriatric fellows actually, and I do plan to start some projects with them once I finish my step 3 soon.
Sounds good. I wish you all the best and good luck with your step 3.
Thank you. I wish everyone the best. And if you have any questions, just reach out, please.
I think Lena,
Yes.
Lynn, go ahead. Maybe question.
Thank you, Dr. You hear me?
Yes.
Thank you, Dr. Mafaz, for the wonderful tips. I recently joined the program, and to be honest, I'm still kind of lost and still a bit confused of what am I supposed to do, and with the studying on the side going on. So if you have like any advices of how to start and how to manage time in regards to studying and being active in a research program.
Yes. So first of all, good luck on your studying process. So the way I would say is like the best advice is to find, if you have an area of interest, just suggested among your colleagues currently. Let's say if you're interested in internal medicine or geriatrics, and let's say the topic is asthma, just provide it to the people or like in the group, just share it that you say that you're interested in researching this area, and then you will have a team of, let's say, 9, and just divide the tasks. Who would initially divide the group into like almost a half, where the first group looks into the current relevant information and data available in the internet, and then the second half can plot it into an Excel sheet. And then once you guys are done, this process might take about 2 weeks, so there isn't much of a rush, but it's important to have a deadline so people do not fall back on their tasks. So once you form a deadline, you're able to, by the end of 2 weeks, from your results, and then the team currently becomes a writing process, or the editor phase, where now you have your Word document and you start the writing process. You write your introduction, you write your methodology, what form of method did you use? Was it a Prisma? Prisma is typically easy because it's a checklist, and this is how you do a systematic review. So you have your title, your introduction, your methodology, your result, and then your conclusion. What did you guys find? What was the result? So by 3 weeks or 4 weeks, this is, I feel like that's almost like the whole process is done. And then you can share it with Dr. Nader. You have your final edits, and then you share it to the journal or the conference that you would like to have it presented there. I know it's very challenging, but having the deadline helps a lot. And then, like, whenever you have any difficulty, just reach out to Dr. Nader or anyone from the seniors or the other colleagues, and hopefully that will always be helpful.
Yeah, thank you. That's really clear.
Thank you. I hope that's helpful.
Yeah, thank you. And did you feel like it was overwhelming at the beginning, or
Yes, so when I initially joined the TGRF research program, also I was very flustered. I didn't know what to start or which topic should I work on. Some of the groups have initially started and they weren't my cup of tea, or I wasn't interested in that title or that study. But then I came up, I believe, with an idea to research. It was during the COVID-19 era, so it was about the effects of COVID-19 on the pancreas in the geriatric population. So just a small topic like that, we formed a group of 9 people, and then we just followed our steps of the Prisma, and we were able to do it. So it is challenging. So if you're not able to find your own topic, it's very natural, it's very normal. Just join any other group, and it's just a learning process for the first research. It doesn't have to be yours. It doesn't have to be 100, like an area that you're 100% interested in.
okay, I understand that. Thank you.
Thank you.
Once again, thank you so much, Dr. Mafaz, for sharing your experience and the tips and answering these questions.
You're welcome. Thank you, Dr. Nader.
Have a great day. And
Thank
any additional comment, please feel free. And if you want to stay along, or if you are busy, we understand you're still in the residency and a lot of tasks or a lot of responsibilities for you.
Yes, thank you. Oh, yes, sorry to cut you off.
No, go ahead. So
Yes, no, thank you very much. I enjoyed coming back again over here, and hopefully once I'm done with my step 3, I will reach out to the fellows that reach out to me, and if anyone else wants to reach out for me, I will leave my email in the comments, so please feel free to reach out. Thank you.
sounds good. Thank you. And we are very glad to have you back, and I wish you all the best with all the stuff you are doing and step 3, and good luck. Thank you. Assalamu alaikum. Dr. Mohammed, when you are ready, and your team.
Yes, I think Dr. Abeer and Dr. Hibatallah are ready. They sent in the chat, so please come forward.
Yes, I'm ready. Let's just give Hibat like a minute to slide share. Okay, so hi everyone. Hello, Dr. Nadir. Good morning, good afternoon, wherever you are. I hope you're all having an amazing day. I'm sorry for the 2-minute delay. We were having some technical difficulties. But yeah, so today my name is Dr. Abeer Hajari, and today I'm here with Dr. Hibatallah Hamid, and we'll be continuing our discussion on cardiovascular diseases, which was first started with last week with the Orange team. So we'll finish off with the second part. Hiba, if you can move to the next slide, please. So today on this presentation, we'll be focusing on valvular heart diseases, cardiac arrhythmias, and peripheral artery diseases. The objective of this presentation is to be able to describe how the cardiovascular system changes with normal aging, the signs and symptoms of the most important cardiovascular diseases in the elderly, and the appropriate diagnostic tests to identify the presence and severity of cardiovascular diseases, as well as the standards for treatment of the cardiovascular diseases. Is my voice clear, by the way? Can you guys all hear me?
Yes, very clear.
Okay. So as we go through these topics, I'll highlight the key clinical features, the diagnostic approaches, and management strategies, particularly talking about the elderly here. So as I mentioned, we're going to be talking about the valvular heart diseases, the cardiac arrhythmias, as well as the peripheral artery diseases. So we'll start with the valvular heart diseases. As you can see from the slide, the major conditions we'll focus on are the aortic stenosis, the aortic regurgitation, mitral stenosis, as well as the mitral regurgitation. In older adults, these conditions are usually degenerative rather than congenital or rheumatic in younger people. So for the diagnosis, echocardiogram is the procedure of choice. Echocardiography with Doppler can non-invasively assess the cause and severity of most acute or chronic valvular abnormalities. It also provides important information about the left ventricular size and function, the left atrial size, the pulmonary artery pressure, as well as the presence and severity of other valvular lesions. However, the echocardiogram is always the procedure of choice. So aortic stenosis. So aortic stenosis is one of the most common and most clinically significant valvular diseases in the elderly. If you look at the slide, you'll see the classic triad of symptoms, which are the exertional dyspnea, the angina, and the syncope. These happen because of the obstruction of the left ventricular flow, leading to the increased myocardial oxygen demand, causing dyspnea and symptoms. So on physical examination, we listen for the crescendo-decrescendo systolic murmur at the right upper sternal border, and this is the key for diagnosis. We can also do an ECG, which will show the left ventricular hypertrophy. We can also hear S4, gallop left ventricular heart heave, which is not specific. It just means there's a pressure overload. For the treatment, if a patient is symptomatic with severe aortic stenosis, the only definitive treatment is valve replacement, either surgically or using a transcatheter. Medical therapy is only done for supportive purposes, and there's no medication that can slow the progression. So moving on to the aortic regurgitation, here we're dealing with volume overload due to the backflow into the left ventricle. So the symptoms here, many patients are asymptomatic for years, but when symptoms do appear, they are often present with dyspnea and fatigue. Patients can also have heart failure, angina, and severe aortic regurgitation. For the findings, the key murmur here is the high-pitched diastolic murmur at the left sternal border. We also see a widened pulse pressure, which happens because of the high systolic and low diastolic pressure. And we can do a chest radiograph, which will show cardiomegaly, as well as pulmonary congestion if there's a acute aortic regurgitation. So for the management,
If the patient is symptomatic or with significant left ventricular dysfunction, we do a valve replacement. And then medical treatment with vasodilators is only done for patients who aren't surgical candidates, or for less severe cases to control the hypertension. And we preferably use dihydropyridine calcium channel blockers, ACE inhibitors, or angiotensin receptor blockers. Beta blockers are used in patients with left ventricular systolic dysfunction too. Okay, but can we go to the next slide? Okay, so mitral stenosis. So mitral stenosis is usually a result of rheumatic fever, even in elderly. Over time, this can lead to progressive obstruction of blood flow from the left atrium to the left ventricle. And then patients can present with symptoms like dyspnea, orthopnea, and pulmonary hypertension. For the findings on the exam, we listen for diastolic rumbling murmur at the apex with opening snap. For the treatment, diuretics for volume overload and beta blockers for decreased exercise tolerance associated with tachycardia. We can also use balloon valvoplasty, which is the classic treatment for symptomatic patients, but most elderly adults are not good candidates due to the extensive calcification and fusion or the concomitant mitral regurgitation that can happen. Surgically, we can do a replacement, which is effective only in 5 to 15% of the patients, especially elderly. So moving on to mitral regurgitation. It can be primarily due to the valve disease itself or secondary due to ventricular dilatation. If you look at the slide, you can see the common symptoms, which are fatigue and dyspnea. All these symptoms overlap. So the symptoms are not what we use for diagnosis. We go to check the findings like examination. Here we see a hollow systolic murmur radiating to the axilla. And we can also see an S3, which indicates a volume overload, pulmonary hypertension, and right heart failure in chronic severe mitral regurgitation. So for the management, it depends on the severity. If the patient has severe symptoms and is symptomatic, we go for surgical repair or replacement. The medical therapy like vasodilators and diuretics are only used for symptomatic relief. Moving on to the next slide. So surgical intervention is indicated urgently for acute severe mitral regurgitation with heart failure, or if the patient is symptomatic with severe chronic mitral regurgitation and the left ventricular ejection fraction is more than 30%, or in asymptomatic patients with severe chronic mitral regurgitation and the left ventricular ejection fraction is from 30 to 60, or if the left ventricular end systolic dimension is more than 4 centimeters. And then when the mitral valve repair is deemed likely to be successful in asymptomatic patients with severe chronic mitral regurgitation and left ventricular ejection fraction more than 60, and in patients with severe chronic mitral regurgitation and pulmonary artery systolic pressure more than 50 millimeters of mercury, or new onset atrial fibrillation with high likelihood of successful mitral valve repair. So transcatheter aortic valve replacement. So transcatheter aortic valve replacement has revolutionized treatment for aortic stenosis, especially in patients with high risk. As the slide shows, it has several benefits, like, for example, shorter hospital stays, quicker recovery, but it also comes with higher risks of vascular complications and stroke, but major bleeding and atrial fibrillation are less common. So it's an excellent option for patients who are not candidates for open surgery. Moving on to the next slide. Okay, so now we're going to talk about infective endocarditis, which is often challenging to diagnose, especially in elderly patients, because the classic signs like fever and leukocytosis may be absent or very subtle. So the native valve endocarditis is most commonly caused by Strep viridans or Staph aureus. Enterococcus species and gram-negative bacilli are also common causes in the elderly, especially when patients with genitourinary procedures. Endocarditis is often difficult to diagnose in elderly, like I just mentioned, because fever and leukocytosis are less common. And these are like the first symptoms that when you suspect infective endocarditis. Transthoracic echocardiogram sensitivity is reduced due to the increased calcific disease in prostatic valves, and the transesophageal echocardiogram improves diagnostic yield for the infective endocarditis. So for the treatment, we give IV antibiotic therapy for 2 to 6 weeks. Surgical therapy should be considered in the presence of severe valvular dysfunction or evidence of persistent infection despite appropriate antibiotic therapy, or in patients with recurrent emboli, marked heart failure, or myocardial abscess formation, or in high-degree AV block, or when the vegetations are more than 1 centimeter in diameter on left-sided valves, or fungal endocarditis. Recommendations for preventing endocarditis after dental procedures focus on providing prophylaxis only in high-risk patients. These patients are those with prostatic valve, prior endocarditis, certain congenital heart diseases, or cardiac transplantation with valve disease. And also recent guidelines have eliminated recommendations for prophylaxis for patients undergoing GI or GU procedures. So you don't do prophylaxis for GI or GU procedures to eliminate enterococcus, for example. So moving on to cardiac arrhythmia. These happen due to age-related changes in the cardiac conductive system, coupled with increasing prevalence of cardiovascular disease at elderly, which leads to progressive increase in the incidence and prevalence of conduction abnormalities and heart rhythm disturbances in the elderly. The age-related degenerative change in and around the sinoatrial and atrioventricular nodes lead to increase in bradyarrhythmia with advancing age. So moving on to atrial fibrillation. Atrial fibrillation is the most common sustained arrhythmia, and its prevalence increases with age. Among elderly patients with valvular heart disease or heart failure, the prevalence is even as high as 30%. So the symptoms related for the clinical features and diagnosis of atrial fibrillation, symptoms related to atrial fibrillation are highly variable. Most common symptoms include palpitations, shortness of breath, or impaired exercise intolerance. In patients with ongoing atrial fibrillation, the standard 12-lead electrocardiogram is diagnostic. Other studies should include echocardiogram, serum electrolytes, especially potassium and magnesium, as well as thyroid function. Further evaluation in selected patients may include a chest radiograph, serial cardiac biometer protein, a brain natriuretic peptide level, a D-dimer, lower extremity of venous Doppler studies, and elevation for pulmonary embolism, an evaluation for pulmonary embolism. That's the D-dimer. So management of atrial fibrillations. The objective is to relieve the symptoms and minimize the risk of thromboembolic events, particularly stroke. So we're concerned about stroke the most. Principal strategies for relieving symptoms include controlling of heart failure, controlling of the heart rate, and maintenance of the normal sinus rhythm. Patients who experience significant shortness of breath, fatigue, or exercise intolerance attributable to atrial fibrillation must be best managed with antiarrhythmic drug therapy aimed at maintaining the sinus rhythm. So we have other alternatives to the antiarrhythmic drugs therapy for the sinus rhythm, which are catheter ablation of the rhythmogenic foci, usually through the pulmonary vein isolation, and the surgical maze procedure. All elderly patients with paroxysmal or persistent atrial fibrillation require considerations for stroke prophylaxis. Okay, so I'm going to stop here, and Dr. Hibatallah is going to finish off with the stroke and the peripheral artery disease, as well, and ending it off with the cases. Hope you enjoy it.
Hello, everyone, and good evening. I'm Hibatallah Hamid, and I'll be continuing from where Dr. Abeer has stopped. So we will continue with the management of atrial fibrillation, this time talking about the stroke risk stratification and the prophylaxis as well. So for the stroke risk stratification, we have the CHATS2 VAS score, which is more accurate than the CHATS score for identifying low risk of the stroke in AFib patients. 2 points is given for age that is greater than 75 years old. 1 point is given for age between 65 to 74 years old. And 1 point is also given for cardiovascular diseases, as well for a female gender. A score of 2 or more in a patient who with atrial fibrillation should make a patient candidate for the systemic anticoagulation. Another scoring system, which is the HAS-BLEED, maybe it's just useful as an adjuvant tool to promote informed decision making by estimating a patient's annual risk of major bleed. As for the stroke prophylaxis, warfarin is titrated to maintain an INR of 2 to 3 in the AFib patients. Aspirin of a dose 75 to 325 milligrams plus or minus clopidogrel is also given. The ACTIVE-WE trial demonstrates that the superiority of warfarin to the combination of warfarin and clopidogrel in terms of both the risk of the ischemic stroke and major bleeding in patients with AFib. Direct oral anticoagulants which we'll be seeing in table 50.4 for characteristics and dosing of the 4 types of direct oral anticoagulants available for prevention of cardioembolic events in patients with AFib. For AFib patients with an elevated score, whom chronic anticoagulation is contraindicated, in this case, we should go for consideration should be given to the percutaneous left atrial appendage closer via the Watchman device. So other types of supraventricular arrhythmias are atrial flutter, which usually occurs in older patients with concomitant AFib, and both anticoagulation and rate control should be considered similar to that of the atrial fibrillation patients. So a patient with typical atrial flutter that is either symptomatic or refractory to the pharmacological treatment, rate control, should be considered for a catheter atrial flutter ablation. Other types also include atrial tachycardia, AV nodal reentrant tachycardia, and multifocal atrial tachycardia. Treating underlying conditions provides pharmacotherapy aimed at rate control or arrhythmia suppression in these patients. In selected patients with recurrent symptomatic episodes, antiarrhythmic medications or catheter ablations may also be considered. And so far we're done with the atrial arrhythmias. We're going to speak briefly about the ventricular arrhythmias as well. So frequent ventricular premature beats, ventricular couples, and short runs of non-sustained that are usually shorter than 30 seconds ventricular tachycardias. In this case, no therapy is needed unless highly symptomatic, in this case, we're going to give beta blockage as the treatment of choice. Longer episodes of ventricular tachycardias with dizziness or syncope. In this case, we're going to need to refer to a cardiologist or an electrophysiologist for consideration of antiarrhythmic drugs, therapy, catheter ablations, or implementation of a cardiac defibrillator for secondary prevention. And so our next topic in today's presentation is bradyarrhythmias. A patient with mild bradyarrhythmia, that is a resting heart rate of 50 to 60, is usually asymptomatic. Patient with more marked bradycardias, that is a resting heart rate of 40 to 50 beats per minute, may experience fatigue, lightheadedness, especially on standing, or reduced exercise tolerance. Pre-syncope or syncope may occur in patients with profound bradycardias. That is a heart rate of less than 60 beats per minute, or an asystolic pause that is more than 3 seconds, whether due to sinus node dysfunction or heart block within the AV node, or an infranodal conduction system. So how do we diagnose bradyarrhythmias? Diagnosing bradyarrhythmias is done by first excluding significant electrolyte abnormalities, measuring of the thyroid function test to exclude hypothyroidisms, and then reviewing the medications. Unexplained pre-syncope or syncope, carotid sinus massage to evaluate for carotid hypersensitivity in these patients. An abnormal response to carotid massage is defined as an equivocal reproduction of the patient's symptoms, example syncope, an asystole for more than 3 seconds, or a decrease in the systolic blood pressure more or equal to 50 millimeter mercury in the absence of the symptoms, or more than 30, less than 30 and equal to 30 in an association with symptoms such as dizziness or pre-syncope. If the symptoms occur daily in the patient or almost every other day, then in this case, a 24-hour to 48-hour ambulatory monitoring may be helpful to confirm or exclude the bradycardia or other heart rhythm disorders in these patients. In patients whose symptoms occur at least once a month, but not daily, a 30-day event monitor may provide a definitive diagnosis. In patients with rare, that is less than monthly, but recurrent symptoms of serious nature, such as syncope with injury, an implantable loop recorder may be considered. So moving on to managing those patients with bradyarrhythmias, first we should correct any treatable causes, such as hypothyroidism, and eliminate potentially offending medications if it's possible in the patient. In patients with confirmed symptomatic bradycardia, not amenable to conservative management, in this case, a permanent pacemaker implementation is warranted. And so moving on to our final topic for today, peripheral arterial diseases. And this encompasses the disorders of the abdominal aorta, renal and mesenteric arteries, the iliofemoral popliteal arterial tree. So the prevalence of these diseases increases with age and is higher in men than in women. Risk factors include hypertension, diabetes, cigarette smoking, and to a lesser extent, in older adults, family history. So, how do we diagnose peripheral arterial diseases? At least 50% of patients with peripheral arterial diseases are asymptomatic or attribute their symptoms to another disorder. Formal history and physical examination to screen for the symptoms and signs of peripheral arterial diseases is recommended in 2 cases. In patients aged 50 to 69 with the risk factors for atherosclerosis, or the patients older than 70 years old with or without the risk factors of atherosclerosis. So the men aged more than 60 years with a family history of abdominal aortic aneurysm, and men aged 65 to 75 years old who have ever smoked should undergo abdominal ultrasound to screen for abdominal aortic aneurysm. So the treatment for peripheral arterial diseases, first we give aspirin of a dose 75 to 325 milligrams. Clopidogrel is also recommended as a reasonable alternative to aspirin in the selected patients. The combination of both of them may be considered in patients at high risk of vascular event and acceptably low risk of bleeding. So ACE inhibitors or ARBs for prevention of cardiovascular events is also reasonable in patients with symptomatic peripheral arterial diseases. And patients with leg peripheral arterial diseases should exercise regularly as well. Another thing to consider in people with peripheral arterial diseases is revascularization. And this is indicated for patients with severe symptoms that are attributable to the peripheral arterial disease. And those symptoms have not responded to aggressive risk factor modification, exercise, or pharmacotherapy. It's also indicated for patients with critical limb ischemia, defined as rest pain, ulceration, or gangrene. In this context, revascularization has been shown not only to improve the symptoms, but also to reduce the likelihood of the subsequent amputations. So we're going to be speaking about the management of the abdominal aortic aneurysm on its own. So the indication for repair in the case of an abdominal aortic aneurysm is the development of symptoms or a rapid aneurysmal dilatation detected during serial assessments, which is more or equal to 1 centimeter in each ear, and aneurysms that are greater than 5.5 centimeters or equal to 5.5 centimeters in diameter as well. Patients with asymptomatic abdominal aortic aneurysms that are 4 to 5.4 centimeters in diameter should undergo repeated evaluations at intervals of 6 to 12 months. Choice of an open or intravascular surgical repair is based on the location of the lesion and the patient comorbidities and prognosis. So we're going to be talking about the shared decision in making of the shared decision making in cardiovascular diseases. So shared decision making entitles patients expressing their preferences and values, and the clinicians providing relevant details of the risk and benefits of their treatment. These are links to websites that talk more about this topic in greater details if anyone is interested in knowing more about the shared decision making in cardiovascular disease. So to summarize today's topic, calcified aortic stenosis is the most common valvular abnormality that requires intervention in older adults. SAVR is the standard treatment for aortic stenosis in healthier older adults, while the trans-aortic valvular replacement is an effective alternative in older adults at moderate to high risk of surgery due to comorbidities, friability, or other factors. AFib increases in prevalence with age, and more than 50% of all patients with AFib are age 75 or older. Most older patients with AFib respond to the rate control medications plus antithrombotic therapy, but some require antiarrhythmic drug therapy or other intervention. Lastly, the prevalence of peripheral arterial diseases. This increases progressively with age, and it's a potent risk marker for concomitant cardiovascular disease and cerebrovascular disease as well. So the management of peripheral arterial diseases should include appropriate treatment for our hypertension, dyslipidemia, diabetes, and tobacco abuse in accordance with the existing practice guidelines. And that concludes our presentation about the cardiovascular diseases. Now we're going to have a few cases to discuss at the end. So case 1 is an 82-year-old man that has been progressively short of breath with excretion over the past several months. He had been healthy throughout his life with no risk factors for cardiovascular disease. Examinations show hemodynamic findings are normal at rest with no postural changes in blood pressure. He has jugular veins are distended at 6 centimeters. There are bilateral pulmonary crackles, and there is 1+ pedal edema, but no cough, pain, or swelling. So which of the following should be ordered first for this patient? A spiral CT of the chest, a transthoracic echo, a pharmacological stress test, or a complete blood count? I will give you a few minutes so you can answer the question. Unfortunately, I cannot see the text box because I'm sharing my screen, but you can discuss among yourselves.
Okay, I can read them for you. So you have
Okay.
B.
Okay. Yeah, the correct answer is B. This patient is presenting with signs of right heart failure. We want to make sure that this patient does not have a valvular disease. And so the first step is to check through a transthoracic echo. The second case, it's an 84-year-old woman that comes for a routine visit. She's concerned about the number of medications she takes and asks why she needs to take preventive medication for cardiovascular risks at her age. She had a small non-STMI 12 years ago, but no cardiac symptoms since. Her medications include amlodipine, atorvastatin, and metoprolol, as well as metformin, acetaminophen, and aspirin. She usually walks up and down her block every day, and she has missing those walks more frequently because of her fatigue. Her examination shows that blood pressure is 130 over 80. Her heart rate is 60 beats per minute. Her recent lab, her hemoglobin A1C is 7.5, and her LDL cholesterol is 80. Which of the following is the most reasonable recommendation for this patient? To stop her aspirin and atorvastatin, to stop her metformin, or to stop her amlodipine and metoprolol, or resume her regular walking program? So the answer for this question is D. As we already talked, with the increased age, there's increased risk for her cardiovascular disease. So we should manage the patient by ensuring that we reduce the risk associated with the cardiovascular diseases. So we shouldn't recommend the patient to stop her medications, but we should recommend her to resume her regular walking program. This is the final case for today. So an 88-year-old man comes to the office for a consultation. He has had progressive shortness of breath on exertion. He has recently had chest pain and dizziness when he walks. His surgeon says that he is too frail for a surgery, but might be a good candidate for transcatheter aortic valve replacement. So which of the following should be considered in the management plan of this patient? A is telling him that transthoracic aortic valve replacement may be less effective for patients who have concomitant mitral regurg and pulmonary hypertension. B is gait speed less than 0.3 can be used to identify patients who will not benefit from it. Patients with more normal Folstein scores are more likely to benefit from a aortic valve replacement, transcatheter aortic valve replacement, and risk scores that incorporate medical measures are more useful than those that incorporate frailty measures. And so the answer is A. Even though people who undergo transcatheter aortic valve replacement have achieved faster recovery and shorter hospital stays, but it's shown to have been less effective for patients who have concomitant mitral regurg and pulmonary hypertension. And this marks the end of our presentation. I hope you enjoyed it, and thank you. If there's any question, feel free to ask.
Thank you so much, Dr. Abeer and Dr. Hibatallah, for the great presentation. I don't know, Dr. Nader, if you have any comments or questions.
No, thank you so much, both of you. Great presentation, excellent work. Thank you.
Okay, I think we can move to the next presentation or the next presenter. Dr. Thilini, are you? Yes, I can see you on the call.
Hi, I'm here. Yeah, I'm ready. Okay. Hi, good afternoon, everyone. Good afternoon, Dr. Nadir. I'm going to talk about what to know about vaping. I hope everybody can see my screen and can hear me.
Yes, loud and clear.
Okay. I'm going to talk about what is vaping and mechanism of the vape pods and the devices and some terms related to it and some statistics and health effects of vaping. So since we practice in US, it's very important to learn about vaping. This is very common in young generation and it's increasingly popular. So we have to know what is vaping to help our patients. Vaping is type of it's e-cigarette actually. It's developed from the cigarette shapes, e-cigarettes in 2007 first introduced to the world, and then it evolved into this type of pods type of devices, and sometimes it looks like USB devices. And then there are lots of names that are used to talk about vaping. It's e-cigs, vapes, vape pens, tanks, mods, pod mods, and these all devices we call it electronic nicotine delivery systems. But it's not only nicotine. There are other substances uses in this, and I'll talk about it in future slides. So this is the anatomy of an e-cigarette. This is the basic layout. It has a battery, mostly it's a lithium-ion battery, and has sensors or switchers to make sure that fumes to come out constantly. And there's an atomizer, which it has a coil to heat up the liquid, which is inside the canister cartridge to make the fume. And then there are different type of cartridges and containers, and this is called something called mod box. It's kind of box kind of a device. User can change the voltage, coils, and wicks to modify the amount of fume that's coming from that. And then there's sub-arm tank, and it has a lower resistant coil to heat up the liquid so quickly. And then there are cartridges that the user can remove and put easily without not like these devices. And there are e-liquids that we can fill to the device, and then these liquids contain sometimes flavors and other type of substances like cannabis and nicotine and many other substances as well. So there are more names that because we have to familiarize, sometimes we have to talk the language of the patient to understand them better, and they will understand us better to advise on these kind of things. And vape devices, we call them electronic cigarettes, e-cigarettes, e-cigars, e-go, e-hookahs, hookah pens, and this is a popular brand named Jules. This brand produced the vaping devices shaped like USB drives, mods, which are large open system devices. They have refillable pod-like containers, and personal vaporizers is another name, vapes, vape pens, and vape sticks. This is how they look like. It's very, sometimes it will be confusing to recognize those devices if we didn't know or we haven't seen them. because they're very similar to, as I said, the USB drives and these kind of pod kind of things, and it's difficult to recognize sometimes. So 35 million people use e-cigarettes in the world according to WHO, and 4.5 of US adults reported to have e-cigarettes. That's 11.6 million people. That's kind of 1/3 of million people who use e-cigarettes live in the US, according to CDC in 2021 data. I think probably it's increased now. So these are adult population. But the problem is the young population has more tendency to use vaping because it is mainly targeted to them, to advertise to them, and also it has some flavors included to attract the young audience, younger patient population. What contain inside these liquids? There are two types of liquids mainly that contain cannabinoids and nicotine. So nicotine comes with propylene glycol, so it can have some other health effects as well. These liquids use nicotine salt rather than free-base nicotine. And liquids in these pods are the problem with the nicotine salts is it is more acidic and it absorbs more inside the lungs than regular cigarette smoking. And liquids in these pods are poisonous when it's allowed to absorb through the skin directly. So if somebody smoke vape in a household with little children, this can be a risk. And an average vape pod contains nicotine similar to 20 regular cigarettes. So it's kind of high concentrated nicotine liquid inside these pods. And there's another term called dripping. Dripping is a method that users use to create a bigger hit of the substance. It is done by increasing the temperature of the heating device in the device, and it create a high amount of nicotine in the fume, and it can cause seizures and convulsions. It is also create harmful toxins like formaldehyde and acetaldehyde, and it has different health effects to patients. And there are myths around vaping. When we advised to patients to smoking cessation, and we have to keep in mind about these things. So because there are people who doesn't know but believe these myths and can get into trouble. So some people believe vaping helps people to stop smoking. It's an alternative method of nicotine as the nicotine patch, but the case in vaping, it does not help to the cessation of nicotine intake, but it has seen increase of usage, and even though sometimes the cigarette smoking stops and the vaping continues, and sometimes they use the both. And another myth is vaping is safer than smoking. It's not the necessarily case. It's true that cigarette smoke has like 7,000 chemicals in the vape cigarette smoke. It's certainly less than the vaping. The more than the vaping has less chemicals than cigarette smoking, but it is not safer. It has a higher concentration of nicotine and acetaldehyde and many other substances. Sometimes these devices can put some other unregulated substances into that, and it's definitely not safer because of these things. And vaping produces harmless water vapor. This is another myth around that people say, and it is certainly not the case. And vaping doesn't create secondhand smoke. It is untrue because vaping does create secondhand smoke. And easy to quiet vaping, it's not really because of the nicotine addiction. It's very difficult even to quiet vaping. And especially teenage brain is more sensitive to nicotine, and it will be very hard for them to stop when from nicotine addiction when they grow up, and nicotine affects pregnancy and child development as well. And what are the health effects of vaping? There are so many health effects. I have listed few, mainly lung injuries and lung health effects. One thing is popcorn lung. This was first recognized in popcorn factories, which they use diacetyl. Those fumes cause lung diseases in the workers. So they banned the diacetyl use in popcorns, but in this vaping practices, the acetaldehyde causing in this fumes cause popcorn lung. And also EVALI, I think many of you have this term. EVALI is the lung injury, e-cigarette or vaping produce use associated lung injury. Is the umbrella term that contains many lung pathologies associated with vaping. And this was first recognized in 2019 as a term, and since then it was declared as there's a pandemic of EVALI, and each case should be reported. So the vaping can cause primary spontaneous pneumothorax and also lung cancer. And there's a study done in University of Ohio, State University of Ohio, and it says the smoking, the people who smoke and do vaping both has 4 times more lung cancer risk than people who smoke tobacco smoke alone. And these are the lung pathologies that are seen in EVALI: acute eosinophilic pneumonia, lipoid pneumonia, acute lung injury and acute respiratory distress syndrome, acute subacute hypersensitivity pneumonitis, organized pneumonia, acute eosinophilic pneumonia, diffuse alveolar hemorrhage, and respiratory bronchiolitis associated pneumonitis. E-cigarette or vaping product use associated lung injury is a respiratory illness characterized by a spectrum of clinical and pathological findings mimicking various pulmonary diseases. As I told, it's kind of a spectrum of diseases. There is an ongoing epidemic of EVALI across the United States. Clinical diagnosis that require use of an e-cigarette in 90 days preceding appearing of initial symptoms is necessary to make the diagnosis. So this is mainly clinical diagnosis, even though imagining can help, like X-ray and CT. We have to exclude all other etiologies to make the diagnosis. The researchers think vitamin E acetate is the most likely substance that associates causing this injuries, but it's not certain yet. And the patient can present with cough, chest pain, and shortness of breath, but also abdominal pain, nausea, and vomiting and diarrhea, and maybe they could have fever, chills, and weight loss as well. There's no definitive treatment, but treatment is supportive until the lung recovers, and you have to prevent secondary infections as well. More than 50% of patients needs ICU care in the past reported patients, out of past reported patients, and by 2020 there was 68 deaths out of 2,800 reported patients. So it's a fatal disease. And as I mentioned earlier, it has like numerous lung pathologies. So chest X-ray and CT findings could be numerous. Like there are many type of findings. So I have mentioned in this link, you can find all kind of pathologies that can find in EVALI. And I have put the picture of lipoid pneumonia, CT measure of lipoid pneumonia. This is one example of a pathology that can cause by vaping. And this another pathology, popcorn lung disease, as I mentioned earlier. This is how it looks like in the chest X-ray, and it is in the CT. These are the references that I use to create this presentation. You can use it. I'll share the presentation so you can read more about it and get to know about that. Thank you so much. Thank you so much. And if you have any questions, please ask.
Thank you so much, Dr. Thilini. I hope I'm pronouncing that correctly.
Yeah, thank you.
Yeah, and I think it's really important and relevant. As you said, it's a pandemic going on. I don't know if Dr. Nader, if you have any comments.
No, I'd like to thank you so much, Thilini, also for this great, excellent presentation. It's important, as you said, Dr. Mohammed.
Thank you, Dr. Nader. You're welcome.
We always learn from you guys, so every day.
Thank you.
Great.
Thank you. Okay, I think we can move to our next presentation. Dr. Haifaa, if you're on the call. Okay, if not, we can move to the following presentation with Dr. Amal, if you're on the call.
Oh, I am sorry. I thought yeah, go ahead with
Oh.
Dr. Amal. Just I want to open the computer. Well, I'm calling.
Oh, yeah, go ahead.
from
Sorry.
my phone. So
Yeah.
go ahead with Dr. Amal, and I will be the last one. So doesn't
Okay.
matter. Just finish your, work today.
Okay. Okay, Dr. Amal, the floor is yours. Go ahead.
Hello, everyone. Are you able to hear me?
Loud and clear.
All right, just give me 1 second to share my screen. Okay, so it looks like someone is still, someone is still sharing their screen. Dr. Thilani, are you still sharing your screen?
I'm sorry, I'm going to disconnect it.
That's fine. Okay, give me 1 second. All right, are you able to see my screen?
Yes.
Yes.
Let me move this one to the second screen so it can be clearer. All right. Hello, everyone. My name is Amal Mohammed. Today, I will be discussing understanding and assessing fall risk in clinical practice with the focus on gait, balance, and the TENET score. Oh, I'm sorry. Gait and balance are essential for more mobility, independency, and overall quality of life. Fall are a major health concern, especially in the elderly, as they are one of the leading causes of morbidity and mortality in this population. To understand fall risk, we must first understand gait and balance. The gait cycle consists of two phases: stand phase, which represents 60% of the cycle, and this when the foot is in contact with the ground. And the other phase, the swing phase, which represents 40% of the cycle. And this when the foot moves forward in the air. Several systems are involved in maintaining balance. Sensory input from vision, the vestibular system, and proprioception. And we have a central processing in the cerebellum, basal ganglia, and cortex. Lastly, motor output involving muscles and joints to coordinate movement. Certain gait abnormalities can increase fall risk. Here are some common types: antalgic gait, a limping gait due to pain, hemiplegic gait, that is a stiffness and reduced movement in one side, often seen in stroke patients, Parkinson's gait, characterized by shuffling pattern and difficulty in initiating movement. A taxic gait, a wide base, unsteady gait, commonly seen in cerebellar disorder. And lastly, we have a steppage gait, a high stepping gait caused by foot drop, often due to nerve damage, most commonly common peroneal nerve. Tinnitus score, one widely used tool for fall risk assessment. The tinnitus score developed in 1980s by Dr. Mary Tinity, a renowned geriatrician and advocate for patient-centered care. The purpose is to assess the fall risk in elderly patients. It has two components: the balance, which contains 9 items, and it contains 60 points. A gait, which contains 7 items, and it has 12 points. The scoring is from 0 to 20 to 28. High score indicates better stability. Score categorized patient into low, moderate, or high for risk. This tool has a significant clinical and research impact. Clinical impact: it provides a standardized, objective measure for assessing fall risk. Research impact: it has been validated in multiple studies. And practically, it's simple, requires no special equipment, and can be completed in about 10 to 15 minutes. Now let us take a look at the demonstration of tinnitus assessment in action. I'm gonna play a video that shows how to perform the test, including both the balance and the gait components. Yes, I'm waiting for it to load. Are you able to see it, everyone?
Yes.
What I'm going to do is demonstrate the Tineti balance assessment. It incorporates 2 parts. It's the balance, and then there's also the gait. The first part of the balance is looking at they're seated in a chair that's armless, and have your feet flat. And what we're doing, okay, is seeing, is the patient listing to one side, or is he in midline? Is he steady and safe? The second thing we look at is his ability to rise from the chair. So, is he unable to? Does he use his arms? Or unable to without help? Able?
And Dr. Amal, can you go back to the screen with the video?
Yes. Are you able to see it now? I'm gonna play it from the beginning.
We are seeing the interpreting the score numbers.
All right, I'm sorry for that. Give me 1 second to share it in the right screen.
Sometimes it's easier if you unshare the screen and then share the screen and select either the window or the tab.
Are you able to see it now?
I'm afraid no.
I'm sorry, yes. let me start it from the beginning. So
Why don't you unshare the screen and then share? When you share, select the video or the whole window. Because we are seeing the slide, the score numbers in the slide.
Yeah, the technical issue.
Perhaps you can you stop the share? The
Yes,
screen?
I'm trying to do that now.
So I'm gonna start from here and you can share again.
Okay. So I'm trying to share the screen that contains the video.
Double click to full screen. Can you do?
Let's see. It's not working that full screen.
Okay, reduce it to small screen.
Okay.
Are you using Chrome or which browser?
Let's see.
The video on which program or app or?
Edge. It is in Edge.
Edge.
Edge
So,
browser.
yeah, so on the top, you can see the file, view, and the menu. Can you see that or no? Or
File.
on keyboard, hit the escape button. It's on the upper left corner. Did it get out of the full screen?
Yes, I'm out of full screen.
Now you can share the screen.
Okay, let me see.
When sharing the screen, there is an option of like an area box. You can draw that box according to the video size.
Okay.
Or you can select the whole window or just the edge of the app, the tab.
I'm trying to share the video. I have 3 screens. I'm trying to share the screen that is with the video both.
Maybe I think Dr. Nader, if she shared the link.
That's another option. Can you share the link of that video on the chat?
I can do that. Okay. It looks like I'm joining the meeting with 2 accounts, maybe that's why.
Okay.
It looks like, yeah. Now, are you able to see it? Let me see. What this one?
I think Dr. Amal got disconnected, Dr. Nader.
That's okay. So I'm gonna take from here and maybe she can join and share the video. So I will let her finish the topic about the TNT score, but I'm gonna share with you guys the other tool. So in assessing the fall risk, we have different tools, and you can use these tools in different settings. Like at the hospital, they can use one of these tools. If you go to a nursing home, you can use a different one. At the clinic, you can use any. So here, I'm sharing with you a fall risk assessment tool. It's called FRAT, and it has also a component where you can ask, or from the history, you can get some score. So for example, if the patient has a recent fall, then you can identify when is the fall, like within the last few months or last few like years or something. So according to what you find in the history, you can get the score from 2 to 8. So the number of falls, for example, one or more in the last 3 months, while the patient is at the hospital or in the nursing home is a resident, then the number will go up to 8. So from history alone, you can get a score. And then if the patient is on multiple medications, specifically the medications that affect their wakefulness, like if they are on sedatives, for example, or other medications, diuretics that can cause hypotension, for example, antihypertensive medication, hypnotics, and so on. So if there are none, then maybe 1 or 0, but if they are taking 1 or more, then you add the score here. The third component is psychological aspect. If they have diagnosis of anxiety, diagnosis of depression, for example, if on examination they appear that way, or if they have a history of that, that will increase the score as well. The last part or section is the cognitive status. If they are mildly impaired, then the risk will go from 2 to 4 according to the severity of impairment. And you add this, and the total will be out of 20. And lower here, you can see the risk divided into low risk, medium risk, high risk. So if it's less than 12, that's low risk. So you worry less about the patient. 12 to 15 is medium risk, and more than 16. Then it's high risk, or more than 15. So if a patient scored more than 15, then you need to put a plan to reduce the risk of falls. You can review the medication, reduce the medications that causes hypertension, for example, orthostatic hypertension, reassess if they need their sedative medications, and so on. At the hospital, some of the hospitals, they put red socks on these patients so that the staff will know that this patient at risk. Sometimes they put them near the nurse station so that if they are trying to get out of bed, the staff will be looking at them, and hopefully they catch them before they fall, and so on. This is other risk factor also you can add to the fall risk, like if they report any difficulty with seeing, they can also add some risk component. Mobility, if they are using any devices, transfer if they need some help transferring, and so forth. So this is one way of looking at identifying patients with high risk of falling. Dr. Amal, are you back?
Yes, I am back. But just
Go
please
ahead.
continue. That's very informative
Go ahead,
information.
you can continue, yes.
One second. So I'm gonna skip the video. I will share it in the chat and just give us like a few information about how to perform the test. I think that may be better.
Yeah, sure, go ahead.
All right. So just I'm gonna read it from my paper. So the Thilini test, it consists of two components: the balance assessment, which is contains 16 points. The first thing, we start with asking the patient to be sitting in a balance. So if it is sitting steady, you give him 1 point. If he is unsteady, you give him 0 point. After that, you ask the patient to rising from the chair. 2 point if he is able or she is able to stand up without difficulty. 1 point, use arm to assess him or her, and 0 point if it's unable to stand. After that, we will see that standing balance. 0 point, 1 point if he's steady while he is standing or she's standing. 0 point if it's unsteady. After that, we notch in his sternum, like 3 times, like tapping in the sternum. 1 point if he's still standing steady, and 0 point if he fall or staggering. After that, you ask him to close his close eye and notice for balance. 1 point if it is steady, 0 point if it is unsteady. After that, ask the patient to turn 360 degrees. 1 point if he is steady with fewer than 4 steps. 0 point unsteady or take multiple steps, more than 4 steps. Lastly, we ask him to sitting down. 1 point if he sit control smooth. 0 point if he fall in the chair. This is a balance part. Now we are going to talk about the Gait assessment. So you ask the patient to walk and assess the patient's ability to walk. You will see the step length and height. That is give a 4 point. If it is like normal, you will give him the 4 point. 1 point if 1 point per each side. Step like you move 2 steps. Do you know what I mean? Like 1 point per each step, like the left and right one, and it is equally. You will notice step length. If it is equal, give 1 point. Step height, if it is higher or normal, if it is normal, 1 point. If it is dragging his feet, that is 0 point. You notice for symmetry, step are symmetrical, give 1 point. Non-symmetrical, give 0 point. Is he able to continue moving? If he is able to step is continue, that give 1 point. If he is staggering or stop, that is a 0 point. Notice the patient going in a straight line or he is in unstraight, deviated, or need a support. That is a 0 point. If he work straight, that is a 1 point. You will notice the trunk stability. Just notice the patient his trunk is stable while he's walking. That is a 1 point. If not, that is a 0. And notice the space between each feet. 1 point if he almost touching the ground. 0 point wide base stance. And that is about the how to perform Thilini test. Now I will share the video link at the end of the session, but I'm gonna continue in the presentation. how is interpreting the TENT score? TENT assessment, the performance. After that, seeing how to perform the TENT test, now we are going to interpret the TENT test. As I mentioned, it's the higher point is 28. So from 25 to 28, there is a low risk of low fall risk. From 19 to 24, moderate fall risk, and less than 19, a high fall risk. So this tool has a significant. I want to use TENT. Use it in elderly patients, those with the neurological condition, or individual with history of fall. And how to use it, we just discuss it. Like conduct, it is easy to conduct. It can take less than 15 minutes to be done, and it doesn't require a high equipment, just a chair. Now we can go to discuss a clinical scenario. So we have a patient, is a 75 years old woman with Parkinson's disease experiencing recurrent falls. Assessment, she has a TENT score of 20. That means indicating she is high, she is a moderate fall risk. So we management plan, we're going to refer her to a physical therapy for Gait training and strengthening exercise. And we can add a home safety evaluation to reduce her fall risk. To summarize, Gait and balance are critical for functional independence. The TENT score is a simple yet effective tool for risk assessment. Early intervention with appropriate management strategies can prevent fall and improve patient outcomes. Any question?
Thank you, Dr. Amal, for the great presentation. I don't know if we have any questions.
Thank you. So before I closing, just I want to mention that I did not create the original slides. They were developed by someone else, and I made the slide modification to it. And I really appreciate the original work.
Okay, thank you so much. Dr. Nader, do you have any comments?
A great presentation. Thank you so much, Dr. Amal. I would like to try again if you want to share the video, see if it works.
Okay, I'm going to try again.
Thank you. Perhaps you can copy and paste the link and paste it in the chat. Thank you. I'm gonna try to share the video from here. This is another video, maybe it's different, but I'm gonna share with you the physiology or the gait examination. Let's see. So the physiology itself, when you look at the patient, when they walk,
Pathologies of gait and the different types of abnormal gaits, we need to just understand the biomechanics of the gait cycle according to the Ranchos Los Amigos explanation. So let's go ahead and talk about that first. All right, engineers, so let's go ahead and talk about the biomechanics of the gait cycle. It's important to remember that the gait cycle consists of two parts. One is the stance phase, which accounts for 60% of the gait cycle, and the other is the swing phase, which accounts for 40% of the gait cycle. If we look and zoom in on one limb, which is going to be Q's left limb, that's going to be his reference limb, and that's what we're going to go through all of the different phases of the gait cycle through. So let's go ahead and start this off. As we see here, Q makes initial contact. Then he goes into the loading response. He goes into mid stance. Now he's in terminal stance. He's in pre-swing, initial swing, mid swing, terminal swing, and back to initial contact. And then we start.
so basically they divide the gait into two parts. The first part when you are stable and then when you are moving. So according to this, you can observe the patient when they walk around. And then there are different ways of assessing. We just mentioned TNT, the scores, and Dr. Amal went into some details, which is great. So I'm gonna share with you different aspects of that as well. So So here, a topic about improving fall risk assessment. This is in the group in assisted living communities. This is an article that was published last January. So we can look at that, and I'm going to share this with you in the chat. But basically, they talk about different aspects of falls and falls prevention, how to assess and how to prevent. At the end, they use some tools to identify which patients are at high risk and how to evaluate and how to prevent them. The other one is the one I was also trying to refer you to. It's called MORSE, MORSE fall scale. This composed of 6 components. So the first section is history of falls. If it's yes, that puts them at high risk. Secondary diagnosis, if they have 2 or more medical diagnoses and they have a list of certain diagnoses. And if the patient is using ambulatory aids, if they are on IV, for example, heparin or IV fluid or IV antibiotics. The 5th component is the gait itself. Are they able to ambulate, or are they using device like a wheelchair? Or the last one is their mental status. So, and if you answer all this, the calculator will calculate and give you an assessment of that patient. You can look at the scores from behind the scene. This is how it's calculated. So if you answer yes for history of falling immediately of previously, the patient had a fall, they added 25 points. If they have more than 2 medical diagnoses from the chart listed, then it's 15 points. If they are using ambulatory aid, for example, walker or furniture to walk around, then it's 15 or 20, 30 points. If they are on IV therapy, then it's 20 points. And lastly, if they are impaired, it's 20 points. Or the last part, I think, is mental status. If they are forgetting, for example, things, then it's 15 points. And you add this, and this is the risk stratification or division into either no risk, and it's low risk, or moderate or high risk according to the numbers here. And this is a list of weight, like the weak gait and so on. There is another one here where you can explore the history of falling, what exactly they mean, secondary diagnosis. And this is things that they may explain to you intravenous. So this elaboration of the test. This is a presentation which is made by the AHRG, the Agency for Healthcare Research and Quality. And this goes into depth as far as training for healthcare providers so that they can know how to identify patients in healthcare setting, for example, at the hospital. If you find a patient who is at high risk, how to identify that patient and how to minimize the risk of falling. It's very, very hot topic, very expensive for the hospital, for the nursing homes, for the assisted living. If the patient had a fall and fracture, it's just not a good thing. So I'd like to thank you for the nice presentation, Dr. Amal. And if you have any questions for any of the presenters, please feel free. If you have any comments, please add them as we go along. Thank you.
Thank you, Dr. Nader, for the wonderful addition. I think we have one last presentation by Dr. Haifaa for the poster presentation.
Yes, thank you for giving me this opportunity. Let me just share my screen.